This recording is the panel discussion that occurred after Dr. Mark Matthews' presentation on his trial on patellofemoral pain. It proved to be very informative, could have gone on a lot longer, in a way that I trust most clinicians will find very helpful in clinic. The panelists are active clinicians and scientists who specialise in patellofemoral pain. And for those of you who are interested in following their work and the work of other experts on the condition that get together every couple of years to discuss the latest research, all their research and others, there's a website on this slide that you can go to for the International Patellofemoral Pain Research Network. I trust you'll enjoy this very informative discussion. Can all the panelists show the video so we can see you and unmute? And I'll introduce you. Claire Roberson, I'll start with, is a principal clinician in the UK, in Wimbledon clinics. I first only knew Claire Roberson as Claire Patella from Twitter handle. It wasn't until I met her at a conference that I thought, wow, it was a real brain bender for me. So she's actually just sees patellofemoral pain over the past 15 years and is an active researcher in patellofemoral pain, does a lot of education of clinicians through her business. Young Bradley's over there in the UK as well. He's a research fellow, sports and exercise medicine, Queen Mary University, and a specialist musculoskeletal physiotherapist, head of research at Pure Sports Medicine. Both these UK experts here are about to rush off to see patients in the real world. So thank you very much for coming on board and making some real world implications for the research. Michael Rathleff is from Denmark. He's a professor in the Faculty of Medicine, Musculoskeletal Health, Centre for General Practice at Aalborg University. I met Michael a few years ago through a visit. He came to see Crossley here at UQ, and we hit it off, and we've subsequently done a few studies. Michael is, for Denmark standards and Europe standards, is young for a professor. If you know of his work, you understand why. He is very much into adolescent knee pain, and there are some questions here about that, so we'll come to that in a minute, Michael. And Kay Crossley probably needs no introduction, but she's a professor at La Trobe University, director of La Trobe Sport and Exercise Medicine Research Centre, which is doing great things. Kay was was the first one to study the McConnell physiotherapy program, and boldly did it against a placebo and showed that there's those short-term benefits. And I've been extremely grateful for all the connections and networking that Kay's brought my way. All the panelists have had clinical experience to various degrees and still do clinical research, so have got some understanding of what clinicians. So welcome everyone, and I should have said g'day and let you say hi, but I'm feeling time pressured now with this bloody list of questions. We did ask for them. So we might start off, do you think if we ask the question of everyone, what do you think, and we'll start with Mark, what would you do now when a patient comes to you and you're thinking, where would you go, orthoses or hip exercises? Mark?
I got to honesty is best policy here. After my study, my heart was broken. I had great ideas that this would answer and give me the questions to the why, and all it did was just give me more questions. So when I had started seeing patellofemoral pain patients in clinic, and they're like, what do I do? I was like, do I be honest with them? So where I'm at now, what I do is I actually talk to them. I offer them the choice, saying, look, there's evidence to show you could do hip strength exercises, and this is why. Or we can do foot orthoses, and this is why. What do you think is going to work best for you? And if they put it back onto me, I will normally start the degree with some degree of exercises, because that's to get the buy-in. But if they're time pressured, if they're under a bit of things are coming up quickly and I need to get a quick change in pain, then I'll start to go down the foot orthoses and look at footwear, foot orthoses, and that sort of approach to kind of get quick pain symptoms down, because it's shown to be effective, and then build in and add into the exercises on top of that. So usually I will start with the exercise approach first, where it could be down the foot or it could be up at the hip as well. But that's where I would normally start, and then just modify as I needed to with the person.
Claire, do you consider foot orthoses at all?
Oh yeah, absolutely. I mean, I work with a podiatrist and an orthotist in my team, so I do. I mean, it's pretty basic, but one of the things that I think is really useful is asking the patients, do they feel that their pain is different in different footwear? Because some patients are really aware of that. And then, you know, if they say, well, yes, you know, when I'm barefoot or I'm in flip-flops or Ugg boots or whatever, I notice my pain is worse. It's an immediate ding in my head, right? You know, this patient may well be a really good candidate for orthotics. Yeah.
Cool. Brad?
Yeah, very much so. I mean, echoing what Mark said, really, I think I'm pretty comfortable being honest with patients and saying I don't think we necessarily know which of these list of interventions is superior. I'm very honest and kind of say, look, we know that most things are more effective than nothing, but we don't know which one is superior over and above and which particular patients are likely to respond. So I think there's a big argument for having that conversation around preference. But at the same time, looking at what's gone before, and that might be reflective of my practice in that I see a lot of people that come for second, third and beyond opinions. And it amazes me how often the foot particularly is ignored. You know, I did a presentation at a conference recently where I put up a participant poll and asked kind of upwards of 1,000 people which of these interventions are evidence-based, and foot orthoses scored really lowly, despite the fact that we've got this evidence. So if I see someone who's had pain for a long time and often the foot's not been explored because of what we know about what's effective and what isn't, I think there's definite value in exploring that.
Michael?
It's sort of like a trick question. Would you pick one or the other for the patient without, like, it's always when we talk about patients with patellofemoral pain, we also need just to appreciate the different presentations and how different they are. It could be a kid that's 12. It could also be a carpenter who's 35 and quite scared about losing his job. So I think before, like, the choice of going in one direction or the other, I think I tend to spend more and more time on understanding the patient and their needs and how can I help them manage their pain. Because one thing is what we do in the clinical situation, but that's just a tiny bit of what they have to do in a full day, where they have to make decisions every 10 minutes on how to manage their health, basically. So along the line, I might pick exercises actually, but just as well for overall health. But as been said before, if they're busy, like foot orthoses offer the same benefits in terms of outcomes, but I think there's some benefits to exercise in terms of just general health for this population.
Yeah, self-efficacy for a start. Okay.
I think I'm going to echo what everyone else has said. I think this is, you know, we're fortunate in many ways. This is a condition that has lots of options that are evidence-based. So not just the hip and the foot orthoses interventions tested in this trial, but if you look at the systematic reviews and the consensus statements and the clinical practice guidelines, we see there's lots of options that have been studied. And so going back, I think echoing what everyone else says, I think it's about seeing what does the patient want to get back to, what is it they can't do, and then saying, well, okay, what are the things that together you think are going to help them best, almost quickly, reach those goals. So for some people, I think it is foot orthoses or maybe even just footwear modification. And for some, it is an exercise program. Like Michael, if I was pushed to make the choice myself, I would probably start with exercise.
So it seems like the patient preference is important in context, social context. Yes, Michael?
Like, you could also ask the question as, like, do they always need something? Something when you have, let's say, when I've seen could be a runner, it could be a young kid with a recent onset of patellofemoral pain for just a few weeks. Do we always need to spend time on exercises and foot orthoses? Maybe it has to do with how much they do, how little they rest, how they do the things that you could actually just start off with the really, really simple things early on, because we can always add layers of complexity of exercises or foot orthoses or taping, but just starting off with the basic things for those with the recent onset should also be something we are comfortable with, despite it's not sort of like evidence-based approach. But the load management, education side of things is something we always need to
Yes.
think about.
Claire, are you putting your pencil up to
Yeah,
yeah, good. Don't be shy, wave it in front of you just in case I miss it.
I think just adding in from that, it's my experience that sometimes patients have had a bit of a cover all bases approach at the same time, because perhaps of this confusion around the evidence base that strengthening is as effective as foot orthoses. And I think patients sometimes get overwhelmed. So they've, you know, and you say, what have you had so far? And I say, well, I've had a bit of tape and I've had something in my shoe and I've had some stretches and some strengthening. And actually, we know from the chronic pain literature that's not good, because if then they're not seeing a benefit, it really feeds into that sense of hopelessness that we really need to avoid in this group. So I'm with Michael, you know, sort of start with some very pragmatic measures on the back of their narrative, and then if necessary, in a reasoned way, yes, add extra things in, but don't start with a cover-all basis approach.
Very, very important message both Claire and Michael have strongly put, and I think everyone's echoed it in their statements, is that, and you mentioned the word, the narrative, what's the patient's story? And that seems to be increasingly important. Michael's done a lot of work with adolescents, and so I know he's told us stories about, you know, adolescents come with a long history of pain at the patellofemoral joint, with many different stimuluses that bring it on, stimuli that bring it on. There was a question by Alex Flood that said, from memory, a Rathleff study in adolescents showed no added benefit when adding exercise to graded loading versus graded loading advice on its own. Do you think this graded loading advice is under researched in the adult population? And then for Mark, could this have been an uncontrolled factor in your study? So, you know, going along a bit of the lines of what's being discussed now, this graded loading advice, where do we use it? How do we use it? And anyone want to throw their hands up for this? Michael, no?
I can go first, of course. As a researcher, you would always say, yes, it's definitely understudied. We need to do more. Please give me funding. But I do think that in the literature of adults with patellofemoral pain, there's been a lot of focus on these specific treatments like foot orthoses and exercises, but very little on what we can do to support the patients on their self-management. And there, I think for these, at least the population that are very, very sports active, we can do a lot, and we should study a lot about how we can give them good advice, sound advice, make them capable of making adjustments to their training volume, their breaks and their pauses and their rest periods. And I think that is something we shouldn't underestimate, including understand their narrative, as Claire said, especially for the very sports active. I think it's like something we all say we do, but do we really do it enough? Because we also know the difficulty in like getting runners to reduce their training volumes for a certain period of time. And it's one of these things that come out of our qualitative work, that it's sort of like a double bind situation that these patients are in, because on one hand, they want to run, or for the kids, they want to run and be part of the football team. But on the other hand, they also know that it actually flares up their knee pain. So they stand in this situation where they have to juggle both wanting to do it, but also understanding the impact of it afterwards. That's where I think what we call like educational interventions could really feed in and teach them how to make these decisions in a meaningful way. So it's not step away and rest or continue full on flaring up your knee pain, but finding this balance in it.
So how do you do this, Brad? You're about to go off to clinic, your patellofemoral patients are coming in. How do you manage this load issue, this loading advice? Where does it fit in your schema?
I mean, again, I think it's important to say I manage it with great difficulty. You know, I see this area of education and load management as being one of the things that perhaps clinically we talk about an awful lot and sort of stress the importance of it without necessarily having anywhere near enough data to back that up. You know, I think it's a real kind of obvious low-hanging fruit that we need to try and look into. You know, I think it's fair to say that whilst we know there's this kind of seemingly subset of patients that get pain with prolonged sitting, generally most patients with PFP don't tend to be overly symptomatic when they're at rest. So I think there's definite value in looking to control how much they do. And I certainly do it with a lot of my group. I work in Canary Wharf, which is a very kind of type A personality dense area. People are always, they're wearing a smartwatch, they've got a smartphone in their pocket, they collect reams and reams of data and then often do nothing with it. So I definitely dig into that and try and help people to get a handle on how much running they should be doing or how much activity they should be doing, their progressions week on week, their volume, their intensity. But whilst at the same time being very honest that I'm doing this based on what I think is sensible, and the reality is maybe at times I'm probably too conservative and people could do more than what I'm suggesting. And I think that's something we really need to try and get a handle on.
Okay, Bradley just said it's low-hanging fruit, mate. Why hasn't it been picked? Why hasn't it been researched?
It's a very good question. We need to do another study, Bill. We wrote an editorial last year about our first RCT that you mentioned, and that study was published in 2001, so it's very old now. And we did a McConnell type exercise, so some loading of the patellofemoral joint using VMO retraining and some hip exercises. And the exercises weren't that progressed. So back then we were told that everything had to be very standardized, and so everyone was given the same thing. And we found a positive effect, so I'm not going to diss my own study. And our study was actually replicated by Natalie Collins as well. So we know that it can be replicated, which is important in research. So we know that this sort of program works. But back then we were thinking, well, it's all about trying to retrain the VMO, and if we can increase the activation, therefore we're going to, change the pull on the patella, and everything was going to be perfect in the world. And then as time's gone on and we've reflected on it a little bit more, I wonder whether what we were actually doing was just gradually increasing the load and the load tolerance of the patellofemoral joint. So the intervention works. It probably just doesn't work by the mechanism that we proposed. And then going back to Brad's question is, I still don't know if my new proposed mechanism is also the mechanism by which it's worked as well. It's just another theory. So I think, as Michael said, there is this real dichotomy of people who are overloading, and often it is adolescents or people that are trying to train for a marathon or do something, obviously highly loaded. And they probably need to be advised to reduce their load, but we don't know by how much exactly. And then there's a population of people that are usually the ones that come into our clinical trials, and they're usually the ones that are the chronic patients, as Claire said, that have seen lots and lots of people and they've gradually deconditioned over time. And they're the people that do need to increase the loading on their patella, but also on their entire sort of musculoskeletal system. And some of that probably can be provided with education alone. And some of that might need extra work. And we're actually playing around, Bill, talking about new research, trying to get some funding to do like a stepped approach where we give everybody education first. That includes why have you got patellofemoral pain, a little bit of talk about the prognosis, and then a little bit of graded activity and some exercises they can do at home. So everybody gets that approach. And then at the end of a period of time, 6 weeks, 12 weeks, whatever we choose, we then say, are you recovered? And those who aren't recovered then go into a more intensive treatment with a physiotherapist, and the actual details of that probably do need to be more patient specific than our earlier trials. So I think from a research point of view, some of these sort of stepped care approaches might be the answer. But going back to your question, Bill, we haven't really had good ways of measuring load in the patellofemoral joint outside of the lab. And if you're going to be brutally honest, we don't have good measures of patellofemoral load inside the lab that can be done easily and quickly and efficiently. And they're very, very time consuming to do. So money is the answer to everything, Bill. But I think now there's a lot of things that are better than they were, 10 years ago. We can get surrogate measures of load from Garmin devices, for example. And the next step really is to see how any data collected in that space could actually be related to either recovery or even why people get patellofemoral pain in the first place.
Yes, money is the answer to everything, and the
Money is
university
the
sector and research have just taken a hit with this COVID-19, especially in musculoskeletal, unless we can show that it's affected by COVID somehow. Claire, you're waving a pencil around. What would you like to say, mate?
Well, you just did the perfect intro, actually. I was going to say that we have a really unique insight into load and its effects with COVID. So I'm finding I've got a very polarized scenario on my hands at the moment. I've got the patients who had improved their knee pain through their workouts in the gym, and in fact had abolished it, and I've not heard from them for months. And all of a sudden, in about the last 2-3 weeks, I've had a flood of emails saying, my knee pain is back, I haven't been able to go to the gym. I'm getting those every day. So that's one side of the equation. The other side is the person who isn't used to running and has thought, right, I can't go to a gym, I've got time on my hands in the lockdown, I'm going to start running every day. And so then has upped their load on their patellofemoral joint massively. And I'm getting lots of those approaching me as well. So I think it's a really unique little insight into the importance of load. Now, I'm not belittling the psychological issues and the trauma associated with the COVID scenario, but I do think there is something around this sudden massive change in load.
Yeah, there's been a lot of talk in the sports medicine literature about what's going to happen to the professional players that have been quarantined, locked down, then all of a sudden get back into Premier League action, and the injury profile and stuff. There's been quite a bit about that, and yeah, so very well, it's good for your business anyway, so the COVID, so maybe that's an angle we should go at. Kay might hit you up for a bit of a grant since you're rolling in patients coming in. Problem is none of them are getting paid to work, so it's a catch-22. Just to give the panel a little rest, Mark, did you control for activity loading in your study?
So yeah, all of the patients in the study all got given an advice or sort of a guidance sheet. It kind of covered the basics around what patellofemoral pain is, kind of a simplistic version of what I presented at the start of this, just around patellofemoral pain and the two treatments sort of thing. And they were given guidance around what they can and can't do with pain. And we were saying, look, if you're experiencing 2 to 3 out of 10 pain, that's kind of okay. You're all right with it. Sort of thing. So there was some big guidance around what we gave with what activity they could do. Was that if they experienced pain during activity, it wasn't to get more than a 3 out of 10 pain, and it must stop as soon as the activity stops and be completely ceased 30 minutes after the activity. Meaning they're not really irritating the bejesus out of that knee. And certainly we said, look, if you're feeling symptoms the next day, you've done far too much activity on that knee. So we gave them a guidance of some sort, look, if you've got more than 3 out of 10 pain, maybe back off, you're doing a bit too much to what the knee can tolerate. It's too irritable to tolerate what you're doing. And this was just sort of a clinically reasoned guidance. So please don't take this as factual evidence-based stuff. You were allowed pain during activity, but it must stop as soon as you stop the activity, and absolutely no morning after symptoms. So that was how we tried to monitor, and everyone across the entire study got given that advice. It was written down on paper and also explained in words as well. We did do sort of questionnaires like trying to track, activities, how vigorous or moderate or sedentary. But those questionnaires are quite fraught with, biases. Certainly some people were Olympic athletes by what they were reporting, if not more, and some people underreported what they were doing. So sometimes those sort of questionnaires like how much vigorous activity do you do on a 7 days? I don't know how these people even slept because they were doing so much activity. So it's a real tricky one. And certainly when we started this study, we didn't have Garmin technology, and I certainly don't think I could get a grant for 300 Garmin Fitbit watches or something that everyone got one and I could track their activity. But with the way that technology is going, most people having them in the use of phones, maybe there's an avenue there that we could start to potentially record it. But that was what we did with the Fox trial, and that's what we did, and that's how we kind of tried to make sure everyone was about the same with what activities that they did. But it's really hard. People's behaviors, some people, as we've seen with COVID, people's behaviors can be completely, leave you gobsmacked. So it's a hard one, and it's no easy answer to that sort of scenario.
You brought up the pain thing, and maybe if I could ask the panelists, because I think this might be clinically relevant, and you can tell me it's not, we'll move on. What do you tell patients about pain, their knee pain with exercise or any of the interventions you're doing? No pain. And Ben Smith's watching, and he'll email me and get up me for not asking this question. So I'm self-covering my ass a little bit. So what do you tell people? How much pain is too much? Mark, you've had your say. No.
I just want to say, when you was asked that question, I was like, I know that Ben Smith is listening to this webinar. I have to be really measured about what I say next. And I just want to say, Ben, I was fully aware that you were watching this. And after that, I'll now a bit.
We'll get a Twitter blast if we don't cover this. Okay, so and who'd like to go first? Brad, what do you? Well, Kay was quick there. Don't hurt your shoulder there, Kay. Yes.
I suppose I was just going to say, like when we did our first study, which we started long time ago, we actually based the 2 out of 10 back then on work that had been done previously by Roland Tomé, and he'd used this 2 out of 10, and that sort of gave us the, oh yeah, that makes a lot of sense, because as clinicians we allow some pain, but we sort of didn't then quantify how much. And so we used that for that study, and I think Natalie's study, and I think Mark in yours as well. But now I think I push that up a fair bit as well. Like I think just over time, what we know about pain sciences, we were also quite obsessed about having exercises pain-free in the 90s and early 2000s. And so I now push that out, and we've got a clinical trial at the moment. Hopefully one day we will start it, where we're now going up to 5 out of 10 in the clinical trial, which may not be clinic. So I just wanted to sort of talk at the history there.
Cool. Brad, what do you tell your patients?
I mean, along very, very similar lines, but my take is generally I'm more interested in that irritability window more so than the severity necessarily. I think the severity of pain during a task is patient specific, and I think the problem with the 2-3 out of 10 thing is it presumes that everyone is pain-free at rest and everyone's pain behaves in the same way, or everyone's max pain is always 10, which it may not be. So I'm heavily guided by the patient in that sense, but I think I call it a hangover sign. I'd say to people, you should wake up the next day thinking, if I needed to use my knee again, I could. Whereas if you wake up and your knee feels a bit dusty, we're probably asking too much of you. And it's more that I'd like you to pull back rather than the severity during. But again, with the caveat that that's based on my clinical experience, and in terms of actual good empirical data, we probably don't have any.
Now, if I could multitask, I would have tagged you and quoted you as the patellofemoral rehab hangover.
Yeah.
Sign. Claire, what do you tell patients?
Again, very similar, but there is a sort of extra dimension that I talked about. If I say, look, I want your pain to be settled within an hour, no more than a 4 out of 10, that's sort of around the area I'm working. The caveat is I say to them, I'm not giving you this advice because I'm worried about harming your knee. And I say, look, we're trying to settle things. And if we're going stirring things up, that's not helpful to our cause, but I'm not worried about harm. So if you do exercise and it is a bit more than the 4 out of 10, or it lasts a bit longer, don't worry, you haven't harmed your knee. Trying to continually move them away from this structural paradigm of hurt and harm, which is so often associated with pain. So I'm very careful to spell that out.
Cool, cool. And Michael, I know you've got certain beliefs about where pain fits.
I think earlier I was very, very focused on it all needs to be pain-free. I would try and tinker around finding that specific exercise that could be done pain-free. And now I think when I actually talk to the patients about doing that approach, they also start to perceive that exercises always have to be pain-free, and they should always and never do things that are actually painful, which I think is a poor or bad byproduct of trying to tinker around with finding pain-free exercises, because the patient might actually take something from it that was never intended. Mm-hmm. The same with when we've used this like pain monitoring scale that we've done in a couple of studies now. We have like 0, 1, and 2, which are green, and then 3 up to 10 is actually red. And now when I think about and I talk to the patients about it, some of them actually perceive that pain becomes dangerous because we had a red color on this like pain monitoring scale. So I tend to not use the numbers now and more just say it out in words and talk about the flare up that they have, and they should be comfortable with that flare up. And I must say, working with Ben on this topic is something that has changed my perception of this dramatically, because it's not about the pain, it's about how we frame the pain. And maybe sometimes a bit of pain can actually be good, because it gives us a nice opportunity to actually talk about what is pain. And as Claire says, is it dangerous to experience pain? No, it provides us with an opportunity to kind of reframe it together with our patients. So I've moved from no pain to actually, hey, it's just pain. We can talk about it.
Okay.
And Ben, the other thing that we've moved to as well is saying, if we give you a new exercise that does increase the load on the joint, we do expect it to flare, and all of the, I totally agree with what Claire and Michael are saying in that space. But if you continue to exercise at that same load, then the amount of pain or discomfort or fear that you feel around that should start to decrease. And so it's around the expectation that if we've actually loaded it enough, it is going to cause some discomfort, but that you will expect that to decrease. And when it starts to decrease, that's when we're going to up it again. And so it's all part of the management that they're going to learn themselves, but this expectation that it's not going to last forever as well.
Yeah, there is an interesting paper for people that are interested, about 2 pages in the New England Journal of Medicine, where they looked at a few hundred people and measured their pain visual analog scale when they came into a hospital clinic or somewhere, and asked them to rate also whether their pain was tolerable or not. And so it seems from that asking a patient simply is, or guiding them, you know, within your tolerance, within your acceptable, what do you think is acceptable? I think that's something along the line Ben talks about. It might be something that is now becoming more attuned with thinking and what you guys have said. There is a question that kind of goes a little bit off this now, but how does our panel approach recalcitrant cases of patellofemoral pain that may have already had management in line with our best evidence? When is interdisciplinary referral indicated? That's probably a good question, you know. So we've got someone, it's been broached in various ways, that have had all the management that's best evidence. And I think Claire said it nicely, sometimes having all the management that's best evidence just damns them if they're not getting better. So two-pronged question, you know, who else should physios, we're all physios in this panel, should physios refer to, and someone that hasn't benefited from all the physical therapy we've thrown at them, and what's your approach with these? I might add, just as a beginner, that anyone that's had pain in adolescence, like there's about 20–25% of adolescents with patellofemoral pain have it well into, you know, the rest of their life. So this is not a small group. This is a real hard question. Anyone like to take a swing at that one, or we go to the next question?
No, I'll kick off if you want. So my thought is always, if I see someone who's had pain for a prolonged period of time and has failed kind of previous episodes of care, I'm thinking about that person landing in one of 2 buckets. I think bucket 1 is the misdiagnosis bucket, and are we actually dealing with perhaps an isolated fat pad provocation, as Mark said about the Fox trial, excluding people that have symptoms into extension, with prolonged standing, with walking, not sort of along the diagnostic terminology we have for PFP. Is there more of a patella tendon involvement? You know, could it be a plica? Could it be Pezan-Serine? Could it be any one of these other diagnoses that masquerade? And if not, the other bucket is, you know, how have they been managed, and have they had a bit of a cookie cutter approach, or, you know, and there's various different sort of paradigms that come out. But one I mentioned earlier is, you know, the foot's just been ignored, and I'm very fortunate. I've got a fantastic podiatrist sitting in the next room, and if I need a foot level opinion, I almost don't have to worry about it. I make a referral, and that patient is then, or that part of that patient's management is then my colleague's problem. So the other one is, I see a lot of people who have very sort of either quadriceps-based management or hip-based management, and never that sort of blend of the two, and quite often quadriceps training's provocative for people, particularly early on, so maybe we need to pull that back a little bit. But at the same time, I'm a big advocate of imaging, and I think involving a good radiologist or a good physician is important. And again, in someone that's had pain for a long period of time, I think that MRI scan can be really helpful, both in terms of that differential diagnosis, and are we are we missing things, but also, is there something there that we just need to calm down? Is there a kind of grumbling sign of itis? Is there significant bone edema? I'm thinking about David Felson's work that gives us a pretty good indication as to which MR findings indicate sort of persistent symptoms, you know, not looking for chondromalacia, but looking for things that might help us manage that patient a little bit better.
Cool. Yes, Claire?
I mean, I agree with all of what Brad said there, but I would say that there are definitely, there's a group that whatever you give them from a physical perspective, you know, they just need a total change of tact, and that then falls into a pain approach. Now, I would then be considering, does it need to be a pain specialist who's going to medicate, downregulate, perhaps overactive pain mechanisms, or actually does it need to be more behavioural, so psychologists? And I regularly use both pain doctors and psychologists, because I think there are, without doubt, there are some patients who you could do, you know, textbook care to, but they need more than physical intervention.
Yes, yes, Michael, you're nodding. Mark, let's put his hand up, Mark.
Yeah. Sorry, I fully advocate everything that's been mentioned before. One of the things I do when I do get these ones, I'm new to Belfast and, you know, working in the clinic and things. So people are starting to hear. One of the things I actually do is just ask them what do they think's wrong with the knee and listen to them. And I want to hear everything that they have to tell me. And often I've found that there's something that's just they're really worried about or concerned about, or there's something about them in the back of their mind. That's number one, is just listening to them and asking them and just letting them talk. You know, there's the old adage that we teach within the course within, I don't know where the numbers come from, so forgive me if this is slightly off evidence, but a person will tell you within 90 seconds what's wrong with them. But the problem is that physios will interject at 23 seconds and start talking over the person. So you've missed 73 seconds of really good information. So what I try and teach in my course is like, look, shut up, listen to the person, let them talk. They will tell you what's wrong with you. And from there, it will then start to give you an idea of like, look, do they just want reassurance through an image? Does this person need to be involved with some sort of counseling service, psychological help, pain services from that point of view? So, and that's something I just wanted to say was like, look, as physios, and I'm so guilty of this myself, I jump on the bandwagon too quickly. Straight away, I was like, oh, you've got patellofemoral pain, and here's what you do to fix it. Whereas if I just shut up and listen, they'll then let me tell them a bit more. And sometimes, not all the time, but sometimes that has really helped me and helped the person. I've been able to say, oh yeah, the first person's actually listened to me and not told me what to do, but just listened and heard back and feedback to them. So that was just a wee bit, but absolutely everything that's been covered before I fully agree with.
Some real clinical gems coming out here is listen to the patient's story has come out very strongly, and let that be your guide. Yeah, I guess when you look at the 3 circles in evidence-based practice, that's pretty much in the center of it, you and the patient, listening to them and then fit the evidence where it fits. Michael, okay, the recalcitrant patient. I also like the fact that the psychology, psychosocials come up a number of places, the narrative, and Claire's mentioned it. And there was a question that we just ticked that off. So one less person that I'm going to piss off when I close this off and haven't answered everything. But Kay or Michael, the persistent, other disciplines, how do we approach them? What do you recommend?
Yeah, look, I agree with both Brad and Claire and Mark, all 3. And I sort of do like the 2 buckets, and I'd almost put like Claire's example in the misdiagnosis, and it may not even be, they might have started with one diagnosis and then, you know, maybe the psychosocial factors become more evident for that person, or perhaps the psychosocial also fits into the inadequate rehab or inadequate treatment. So I think they're the main 2 things. I suppose the other thing that we are increasingly aware of is body mass as well. It is an issue in patellofemoral pain. It's an issue in progression of patellofemoral pain. It's certainly an issue in patellofemoral osteoarthritis if we were to go all the way down the line. So I think having the conversation with your patient and maybe getting involved a health professional in that way, if it's needed, I think is something else we should consider. But I think it's also, like, as clinicians, we have a whole lot of tools in our toolbox, you know, so we're really good at exercise, or we're really good at load management, or we're really good at foot orthotics, or all 3. But then we've also got, you know, hands-on treatments. Don't want to get myself shot down, but, you know, we can use those if we want to. You know, mobilizations and massage and stuff like that can actually help with patients' pain to allow them to move to the next step. So I think there are lots of things that we can do. And I also think the more we do exercise prescription, the better we get at actually getting the effect we want with exercise prescription or load management. So it may be that, as Brad says, they've done heaps and heaps and heaps of inner range single leg squats, and all that's doing is aggravating, but that doesn't mean that exercise isn't part of the solution. It just means the way they did their exercises might have been the problem.
Cool. And Michael?
Yeah, I think it's good input all the way along. And I think the only thing to add is that the longer it persists, the less important it is to consider it patellofemoral pain, but the more important it is that we consider that we have a patient that is suffering from chronic pain, and then start to look into the horizon about what do we know from the broader field of managing patients with chronic or persistent pain complaints.
Cool. I'm aware now we're getting on to 2 hours, and I think a few of us have got work to go off to, and a couple of us would like to go have dinner and wine. And we're the eldest here, so I think we pull rank in that way. So I'm going to wrap this up, if that's okay. Does any of the panel have anything in particular they want to say that hasn't been said that you think's important to say before we sign off?
Can I just chip in with one thing I forgot to say, is that sometimes foot orthoses, it's been labelled that perhaps foot orthosis is it's a symptom modifier and doesn't treat the true underlying, and I've listened to a few podcasts where that word has come up, that foot orthoses they just modify symptoms, but they don't treat the true driver behind a problem. And I have not an issue with it, but I view it slightly different. It's like, look, if you can, and as Kay's just said it just literally then before, if you can modify symptoms, that then may allow them to move a bit easier and move in a different pattern. So, you know, don't be stuck in this mindset, I've got to treat the driver and ignore the symptoms. You know, all these little things can help you. And foot orthosis or hip exercises, and that's kind of where I wanted to sort of finish my contribution to this discussion, was like, there's lots of ways we can do. If we can modify symptoms, we can change this. If there's ability to come from a different angle, then, you know, go with that one from there.
And we've
So
kind of got we've got an analysis of your data that I won't tip the answer off, but we've looked at what are the mechanisms and what are the potential mediators, and we'll be submitting that paper soon. It's in my to-do tray to get back to my colleagues on that. Yes, the mechanism by which these things work, I think, is almost another hour's discussion. I don't want to start that off. So thanks very much for your contribution, Mark, and for your presentation, Kay.
I just want to say massive congrats to Mark. I think if no one's done a clinical trial, they don't understand the difficulty in recruiting that enormous group of people, and obviously the work that Michael did in that project. It's a huge achievement, and yeah, just massive congrats to you. And thanks to Bill for inviting me to be part of this great team.
Thank you all for coming along. I think we were very lucky to have Kay and Michael both on this project, to have someone like Mark that has got the capacity and the lived experience with life to actually drive a study like this at PhD. He lost some hair and didn't go grey, but
they're starting to show up. As I started to write this thing up, all of a sudden my beard just became grey, and I was like, oh my God. So now keep it short and you can't see him.
I'm not going to talk about grey hair.
I think we might wind up now. I'd really like to thank everyone that's come along, and particularly Claire, Brad, Michael, Kay, and Mark for giving of your time. I guess I'd like to finish off. We live in some interesting times with COVID and that. So all the attendees, thank you very much for attending. I will endeavour to get the recording of this, if it's all worked, online, and I'll email you about it. And for those that couldn't make it or had to go, they'll get that. But I'd end up by saying, have a stay safe and well, and let's all contribute to helping people with their musculoskeletal patellofemoral pain in this interesting time. So thank you very much, everyone. Really appreciate the discussion. So I'm going to push end so you can all go home or go to work. Have a great day or evening. See you guys.
Thanks, everyone. See ya.
Bye.
Bye.